Okay, today we are going to start the rest of the thyroid gland. And the thyroid gland, so far I discussed, the last discussion was modalities, diagnostic test and imaging modalities, and I discussed about the elastography. There is the new modalities came up in the market, and definitely it's gonna get more business. But ultrasound so far is the best modalities that we are using for thyroid gland. And we have to understand that any person having an exposure to the radiation, even though somebody works in the radiology department where the radiation is there, thyroid gland may absorb extra amount of radiation. Other than thyroid gland, the bone marrow can absorb the radiation for the man testicles, can absorb more radiation. That's why they need to be checked every 2 weeks how much radiation the body has, because the radiation causes mutation. What is mutation that we taught? Mutation means changing of the genetics, gene. The genetics, the base pairs, they altered. When they altered the sequence of gene, it means different. That is the biggest challenge. It means different. That means that signal indicates something else. And that is abnormal proliferation of the abnormal cells, undifferentiated cells, and that is malignancy. So thyroid can have malignancy too. Keep that in mind. When we scan the patient, we took the history. We must need to take the history, his or her occupation. And any time in the lifetime, did he or she get any exposure of any radiation in the neck, in the chest area, for any reason, because the radiation exposure can cause disease in the thyroid gland. So now I will discuss about the sonographic technique and appearance of the thyroid gland. Sonographic techniques. Sonographic techniques and sono appearance of the thyroid gland. Sonographic technique, we have to understand the thyroid gland is superficial. Superficial organs. And this superficial organ deserves high frequency transducer. High frequency transducer. And we use linear sequential transducer. Linear sequential transducer. Why high frequency? Why high frequency transducer we used for the thyroid gland? And what level is high frequency? 5 megahertz, 7 megahertz, 10 megahertz. I'm going to pick 10 megahertz because the high frequency transducer will improve the axial resolutions and also lateral resolutions. Both resolutions will be improved. And as a result, quality of the picture, quality of the image is improved. Okay? So this is important. They might give you one question. In your laboratory, ultrasound lab, there's a 5 megahertz, 7 megahertz, 10 megahertz. Which transducer are you going to use? You have to use the highest one. In our lab over there, 12 megahertz. Even though I have 15 megahertz linear sequential transducer. Okay? So, higher the frequency, it is better for the superficial structures. Thyroid gland is a superficial structures. And linear sequential, because curvilinear we don't use it. Curvilinear usually used it for the deeper organ. But curvilinear transducer, I can use it only for the measurement. Sometimes you will see you are measuring the thyroid gland. Thyroid gland is so enlarged, it does not fit in the image, in the linear sequential transducer. So then only for measurement, which measurement? Length? Yes, only for length measurement I can use the curvilinear transducer. They might ask these questions too. Nowadays, so ultrasound machine has a panoramic view. So panoramic view means it is a camera, you know, panoramic view. With the movement of the transducer, you can get the whole length of the thyroid gland. Okay? So, this is the thyroid gland superficial, this is a transducer. Is there any patient's preparation? Patient's preparation. Patient's preparation. Practically no patient's preparation. No preparation. No preparation, that means there is no nothing by mouth, there is no bladder filled, and no preparation means, but no preparation, only the jewelries is not allowed, and no turtleneck, dress. You know, a couple of dress, it covers up to neck. So you're going to give the instructions to the patient that this is your disposable gown, please get it. And if you have any dress that covers the neck, and if you have any jewelries, please take it off. Okay? So that is a transducer selection and patient's preparation. Patient's position. Patient's position. What would be the patient's position? Supine with hyperextended neck. Why? Supine with hyperextended neck. So how are you going to get the hyperextended neck? You have to put the pillow or towel, not here. You're going to put the pillow and towel here, so that automatically neck will be hyperextended. When the neck is hyperextended, but make sure patient has no pain in the neck, patient has no disc prolapse, patient has no spondylitis, and patient has no Parkinson's disease, because Parkinson's patient, they got tightness of the joint. And if you force them to make the neck extended, they will shout, cry, and they may say, I don't want that. Okay? Now, then you can think, if the pain is in the neck, that means so what? I cannot do any ultrasonography. I have to send the patient back. No, don't send the patient back. Out of 20 images, as much as possible do it. If you get 12 images, 10 images, get it. Then write down, please, on the note that patient has a limited or restricted movement in the neck. Patient could not cooperate. You have to write it down, otherwise radiologist will not believe or will not know that this patient has a neck problem. Okay? So this is very important. And do not force any patient for hyperextended neck. Sometimes you will see patient has a high blood pressure and patient came for the neck exam, thyroid gland exam. For high blood pressure, you will see the carotid artery is tortuous and is jumping all the time and is making or shaking the thyroid gland. You may not get the good view, but try. Okay, so now you have to, this is the patient position, and then swiping the organ, swiping in both SAS view and transverse view. Why swiping? Swiping will give you a quick evaluation. It takes only maybe 30 seconds, not even 30 seconds. If there is a pathology, then you can see, oh yes, there is a pathology here. Okay, and if there is no pathology, then you can have a fresh mind. Oh, I saw preliminary that there is no pathology. That means it is an easy case. Okay? Now, after swiping, then make sure you explain the procedure. You explain the procedure and give the instruction. You have to give the instructions to the patient. What instructions? If you feel any pressure while I am scanning you, please let me know. Sometimes it happens. You know, the jugular vein is so superficial, right here? And jugular vein drains the blood from the scalp area, face area, neck area. And you are scanning, and all the time you see the jugular vein is undercompressed. So then patient, all face congested. Patient is looking at you like this. Then you have to understand what's wrong. Tell the patient that if you feel any pressure, tightness, congestion, please let me know. Okay? It is very sensitive area. Instructions. And also tell them that I'm not supposed to tell you anything. So radiologist will make a report for your doctor, and that your doctor will talk to you. And usually it takes 1 to 2 days. Just tell them everything. Then after instructions, privacy. You have to maintain the privacy. Then start scanning. start scanning. So one thing I'm going to teach you, that while you will be scanning, how are you going to start? You have to start in transverse view. Both thyroid gland you can see. Okay, the first image you have to take so this is thyroid gland. You're gonna get why this is transverse both lobes. So now, while you will see the thyroid gland, what you are going to see, in both lobes, you are going to see the size, shape, comparing, then echogenicity, then texture, then vascularity, any calcification, any mass. The mass can have enhancement, and shadowing. Okay, so these are the things we need to see in order to compare both lobes. Sometimes you will see, usually the left lobe is a little smaller, but you have to see. You will know that size, the length, usually we know the length could be say 4 to 5 centimeter, the width could be 1.5 to 2 centimeter, and the height could be 2 to 3 centimeter. Shape, so boat shape or oval shaped in sagittal view. Comparing both lobes. About everything. Echogenicity. It is homogeneous, medium level, hypoechoic. Texture, coarse in texture. vascularity, so both have medium level vascularity. Once you set up the color gain, you have to finish the whole protocol with the same setup of the color gain. Don't change it. Vascularity is one of the important way to understand an organ has an infection or no infection, has a mass that is malignant or not malignant. So in malignancy, in infection, the vascularity goes up. And now any calcification means deposition of the calcium, that causes bright echo followed by shadowing. Shadowing not always. I saw a lot of cases there is no shadow, but there is a deposition of the calcium, calcifications. Then what does it mean if you see the calcifications? Certain organs calcification is a precancerous, but certain organ calcifications it is no cancerous, like thyroid gland. I saw thyroid gland calcifications. Then I saw in the uterus calcifications, but they are not precancer. But in the breast, microcalcifications is very important. And the any mass enhancement, if that mass is enhancement, so mass enhancement comes from the cyst, mostly it is cyst, and the shadowing is a solid mass, solid malignancy. Solid and malignancy. Okay, so these are the things we need to keep in mind and during the total protocol. And you have to take this image, transverse both lobe without color, and next one is with color. So make sure you understand all those things. So now let me give you the rest of the protocols. So we will use the sagittal and transverse view of protocols, and we will measure the isthmus. So in this view you will measure the isthmus outer to outer. Okay, make sure you get the measurement of isthmus. Isthmus usually 2 mm to 6 mm. Isthmus is a functioning tissue. Isthmus can have a tumor, isthmus can have a cyst, so anything can happen. Okay, all sagittal view. Sagittal view, so if it is 1 and 2, because without color and with color. So number 3 here, sag mid right thyroid, and number 4, sag medial right thyroid, number 5, sag lateral right thyroid. Sag mid right thyroid without measurement and with measurement. Which two measurement? The length and height. Length and height. So in sag we are measuring the two measurement. One is the length, another is height, and medial and lateral. So medial, it comes with tracheal ring. When you see the tracheal ring, then it is medial. So above the tracheal ring, that or anterior to the tracheal ring, that is isthmus. When you get the tracheal ring, then come back. Come back, whatever the tissue you got, that is the medial portion of the thyroid gland. Okay, so with tracheal ring, sometimes you will say you are getting the medial portion of the thyroid gland with tracheal ring. It comes like that too. Okay, so not necessary that you have to take the tracheal ring along with the medial part. No, tracheal ring is your landmark. Once you got it, then come back. The lateral, it comes with common carotid artery. Here the common carotid artery is a landmark. You have to go all the way lateral and you get the common carotid. Once you get it, then come back. Whatever the portion you see while you are coming back, that is lateral. Okay? So now I am going to draw the diagram for the sagittal, mid sagittal. If this is your image, so if this is the thyroid gland, make sure thyroid has a nice capsule around it. So you have to measure from here to there. It's a length, and you're going to measure from here to there. This is height. This is sag mid. One image you're going to take without measurement, and second image with measurement. And sag medial. Sag medial, I'm just giving you a little idea. Once you're going to see the tracheal ring, then you will see the thyroid tissue. This is isthmus. And below, once you're going to angle towards the medial, towards the mid from the trachea. Okay, so this is trachea. Trachea. And this is medial. To get the medial, you don't need to get the tracheal. But if it comes automatically with the medial, keep it. But usually we don't take the isthmus with the medial. But there are some protocol, they want to see the isthmus in sagittal view. So that's the way you will see the isthmus here. Okay? And the lateral, you will see the carotid artery here. You will see the carotid artery. That is your landmark. Because now you have to come back towards the medial. Okay, so now once you get the common carotid artery, then come back and common carotid artery will be disappear. Then you will see a little piece come up. So this is